Welcome back to PedScript. I'm Zach Hodges, a pediatric intensivist from the University of Texas Southwestern in Dallas.
And I'm Alice Shanklin, a pediatric intensivist at Cohen Children's Medical Center in New York.
And we are so excited to be discussing BPD with Dr. Audrey Miller. Dr. Miller, will you please introduce yourself and share with us your clinical and academic interests related to today's topic?
Sure. Hi, I'm so happy to be here today. Thank you so much for inviting me into your podcast. I'm an attending neonatologist, and I work at Nationwide Children's Hospital and Ohio State University Medical Center. And my whole world is BPD, bronchopulmonary dysplasia. So I do most of my clinical service with our BPD team, and I am fortunate enough to be the medical director of our BPD unit as well.
Oh, well, that's wonderful. And we are so glad to have you here talking about this topic.
Thank you.
Yeah, this is big for PICUs. So how did you get to the point of being the medical director of the inpatient BPD unit? There are so many careers available in neonatology. Can you tell us about your path?
Yeah, absolutely. So I have loved BPD as long as I've loved pediatrics. And I think that was just how my training evolved. So I had the wonderful opportunity to train with Dr. Al Guest, who was a neonatologist that set up the BPD program here at Nationwide Children's Hospital about 20 years ago. And his career path brought him to the hospital where I did my residency and my fellowship. And so I was able to work with him for a very long time and saw very quickly just how these outcomes vary based on the treatment they receive. And it was so eye-opening to me that these patients can do really, really well, or they can do really, really poorly. And it's up to us in many aspects of that. So I got really inspired by that. And that specifically led me here to Nationwide because they are so well known for BPD, and I wanted to make BPD my career.
That's wonderful. Will you tell us more about the BPD Center there at Nationwide? It's unique. It has exceptional services offered. Please brag on yourself.
Sure. That's hard for me to do, but I'll try. It's easy to brag about the unit because the unit is incredible. It's the only BPD unit in the world that I know of. It's a 24-bed ICU, and we only take care of patients with BPD. We admit about 120 to 130 kids every year with BPD, so we have a really high volume. We take care of the most BPD in the country. And that's definitely a mix of our own patients, but we've also become a national referral center for BPD, which is very unique. So at any given time, about a third of our patients are from other centers all around the country. We have really great outcomes. I think that's why we get a lot of patients coming to us from other centers. We have incredibly low mortality, very low trach rate, really great neurodevelopmental outcomes, and really great growth outcomes. So the unit itself is amazing. I'm incredibly proud to be part of such an amazing team where everyone is so dedicated to BPD and have our own bedside BPD staff, like BPD nurses, RTs, our own BPD dietitian. It's really just an amazing team effort for these babies to give them the best outcomes we can.
That's wonderful. And, something we'll explore later in today's conversation is how these patients with severe bronchopulmonary dysplasia, they sometimes sit somewhere between NICU and PICU. And for your local unit, is that staffed by neonatologists or are there any pediatric intensivists?
Yeah, so you bring up a great point because almost everywhere else that I know of, there is this shift between these babies going from NICU to PICU, whether that's age related or level of support related. But for us, we're really unique in that we keep our patients till discharge. We're very fortunate to be able to do that with bed space and don't have pressure from insurance companies. We're really fortunate. So our ICU is run by neonatologists. We manage these babies till they go home.
Well, that's wonderful. So inspiring to think of everyone just focused on getting the best possible outcome for these patients.
Thank you.
So, Dr. Miller, before we get started, we ask everyone, do you have any relevant conflicts of interest to disclose before we get started?
I do not, no.
Wonderful. Alice, you want to give us a case?
Absolutely. So we're going to give you a 6-month-old infant born at 23 weeks gestation with severe BPD, who is now tracheostomy and G-tube dependent. This patient is being transferred from the NICU to the PICU for management of chronic respiratory failure and ongoing care needs. Over the course of her first week, she's noted to have several periods of agitation followed by severe hypoxia requiring rescue by the medical team despite multiple IV sedative infusions and ventilation using a lung protective strategy. So before we get started on your thoughts on this case, What is bronchopulmonary dysplasia? What pathophysiology is happening here? What should we know just right out the gate?
Yeah, great question. So it's a unique disease in the sense that its diagnosis depends on the level of support at a certain time point, which is very imperfect. But to get the diagnosis of BPD, you have to be on respiratory support at 36 weeks corrected age. And then it stratifies out between grade 1, 2, and 3, or severe BPD, depending on the level of support you're requiring. So for this patient with severe BPD, they were still on the ventilator at 36 weeks corrected. When you dive into the physiology of BPD, it's so important, I think, to understand this because it dictates exactly the ventilator strategy that works so well with them. They have this very unique heterogeneous lung disease, which is hard to wrap your mind around. It takes me a long time because there's parts of the lung that are very healthy and they have normal compliance, normal resistance, normal time constants, but that's the very minority. There's not a lot of healthy lung. Most of the lung is then either stiff and scarred and fibrotic or atelectatic. And the biggest portion of the lung that we see, the most cross-sectional area that we know from studies in these patients, is an obstructive component with hyperinflation and air trapping because of a really high resistance. So it can be complex to think about all these moving parts in the lungs of BPD. But I think, the way I talk to trainees is to simplify it to think about most of your lung has relatively normal to lowish compliance. The air comes in pretty easy, but most of your lung has an incredibly hard time getting air out. It has such high resistance that it takes a really, really, really long time to get the air back out. And so if we're using a strategy where we're pushing in breaths before the baby is able to exhale, that's when you start to see this hyperinflation, overdistension, obstruction, and worsening VQ matching, and ultimately you see that in your clinical status of your patient.
Will you tell us more about how these healthy and then also these scarred lung units perhaps ventilate differently? Tell us more about how this unique pathophysiology directly impacts the ventilatory strategy.
Yeah, absolutely. So the healthy part of the lung is going to ventilate no matter what you do, which is why, depending on the severity of the patient, some patients are able to kind of limp along in a lung protective strategy for a certain period of time. But the areas of the lung with a really high resistance, they're not going to ventilate with a lung protective strategy. What they require is enough time to exhale between breaths. And when you're thinking about the ventilator settings you're using for that, that's a really low rate, right? And then, we can talk more about that, but if you're going to have a low rate to allow full exhale, full emptying, then to maintain your minute ventilation, you're going to have a high tidal volume. I tend to think about these lungs as very long time constant. So because that resistance is so high and your compliance is relatively normal, your time constant is going to be really long. And I tend to lose people when I start talking equations. So
oh, not our audience. Okay. This is PICU pride. Okay. Resistance times compliance. Okay. So long time constant in the damaged areas of the lung.
Yeah, exactly.
Let me highlight something, and please critique me if I'm wrong. I think we need to contrast this to ARDS. So in ARDS, we think about much of the lung parenchyma all dealing with a hyperinflammatory issue, whether it be direct from pneumonia or indirect from sepsis, et cetera, where the strategy there really is you need to deliver small tidal volumes because air goes in usually pretty uniformly, and then exhalation is usually pretty quick. Usually it's not one of high resistance. So that's where our quote lung protective strategy, no more than 8 mLs per kilo, usually even a higher respiratory rate because of their ventilatory needs. BPD, on the other hand, the pathophysiology is quite different. The only way you're going to ventilate these scarred lung units is by giving them an adequate tidal volume, adequate inspiratory time. But because of the resistance is so high, they need a very low respiratory rate so they can exhale. Is that right?
That's exactly right. It's night and day compared to ARDS. And because there's those stiff fibrotic areas, you need enough of an eye time to make sure you're getting the air in. It's not going to be homogeneous like with ARDS or for any neos listening like an RDS picture. So you need enough time to get the air in and a lot of time to get the air out. When you listen to these babies on clinical exam, It takes so long for their exhale to finish. If you're pushing air in before they're done, you're just going to worsen your VQ matching.
It's interesting to me about BPD that this is not every infant of a certain gestational age. What's happening to some of these premature infants that's putting them at risk for BPD? Is it known?
Not 100%, but we know there are certainly risk factors. We don't know the precise mechanisms that are happening, at a cellular level per se, but we know that babies who end up having the most severe forms of BPD, usually the babies that require tracheostomy, they're having problems related to their lung development. They're having further lung injury, and then there's usually abnormal lung repair. And so for clinical context, that would be like injuries to your lung in terms of development would be those really early babies, 22, 23, 24 weeks, where lung development by the time they're born just really isn't where you want it to be. Certainly, if you have even older preemies that have really bad IUGR in utero, that impacts how lungs are developed. And then there's compounding injury once these babies are born. So if there's sepsis or neck, certainly require mechanical ventilation, that leads to further lung injury. And then we do know that some of these babies have abnormal lung repair, specifically related to postnatal nutrition and postnatal growth. And the sickest babies usually aren't getting fed. So that just compounds that injury for repair too. So there's all these kind of factors weaving together, and we're not sure exactly how it all fits together precisely. We just know these risk factors tend to lead to the super severe BPD phenotype.
And then when we take care of patients with severe BPD in the pediatric ICU, if perhaps we're on the receiving end of a transfer, we might just find a child on extremely high peak ventilator pressures with seemingly quite a lot of morbidity, whether it be tracheostomy, G-tube dependence, and whatever other complications arise. And then with a transitory nature, we might not see that child again for a long time. What is the general trajectory for children with severe BPD? Is there a chance that some of these children might regain lung function and be able to be liberated from mechanical ventilation, or do we know that?
Yes, great question. Yes, we do know that. We recently just did a study in the collaborative where we were looking at long-term outcomes for babies with BPD. So we know that it gets better if you survive. It just takes a very long time. These babies who have such severe disease they require tracheostomy and home mechanical ventilation, if they survive, if there's no mortality related to the trach itself or complications, almost all of them will be liberated from the home ventilator. It just takes a long time. The median is about 2.5 years of age by the time that happens. Those kids are getting decannulated as well. The median age is around 4. So it does get better. It just takes a very, very long time to do so.
Wow. Yeah. 2.5 for liberated from the vent and then 4 for decannulated. That's important to remember. It's so easy to feel like after spending a long time in the NICU as Gen Peds resident and then you come to the PICU, but we literally don't see those kids.
Yeah.
How would you characterize the other complications, or how do these kids do from a neurodevelopmental perspective?
Yeah, so it to some degree depends on the center and the management approach, which is my biggest goal of my career is to uniformly have some type of management guidelines, some type of support on how to optimize outcomes as best we can. But we know that most of these kids do have neurodevelopmental impairment, certainly are at risk for CP, behavioral problems, motor problems down the road. They have a high risk for that. And the risk factors for having neurodevelopmental delay and severe BPD are very multifactorial, of course, as you can imagine. Just being born early, some of them have intraventricular hemorrhages. And then how we manage them impacts their outcomes as well, because a lot of them will have exposure to neurosedatives. A lot of them will have consistent pain sources, which we know impacts development down the road. So there's multiple factors going into this, but they are at risk for neurodevelopmental delay for sure.
And taking care of children with severe BPD, it seems that a significant portion of them have pulmonary hypertension. Do you mind just telling us more about this close link between the two and the significance that you see when these children have comorbid PH?
Yeah. So nationally, it's kind of about 1 in 4 kids will have BPD-associated pulmonary hypertension. Certainly, it goes back to being born premature and having immature vascular development. But I'll tell you I'm being honest, we inherit a lot of kids with BPD-PH, and just simply optimizing the support, the respiratory support, and making sure they're saturating well consistently, we see it melt away. It's definitely a big complication. We know it has a high mortality. It certainly used to have a much higher mortality than it does now. But there's ways to really improve it without even going down the route of like sildenafil and nitric, just by optimizing the respiratory support and taking away that kind of chronic intermittent hypoxemia that we see in these kids.
I mean, it goes back to the physiology, right? Like the patient who has PH, if you can optimize their oxygenation, their pH, their lung volumes, it's probably going to do a lot more than, somewhat more fancy medications would say, like sildenafil and nitric oxide.
Exactly.
But not just to stabilize them, but to optimize their vasculature development as well, it sounds like, right?
Exactly.
Not acutely, but chronically.
You need a comfortable baby to achieve growth. With these BPD kiddos, because they require such a low rate, you need a high tidal volume in order to maintain your minute ventilation. And then our biases come into play about using such high tidal volumes and high PIPs. And sometimes our kids are a little undersupported.
Yeah. So when I was preparing for today's talk, and I would say as a caveat, I know almost nothing about neonatology outside of just what I get to glean from our neonatologists that consult sometimes with us. But it seems that over the course of a baby's course in the NICU, from being a premature baby in those first days of life, there might be somewhat of a lung protective acute ventilatory phase. But after it becomes apparent the child is developing chronic lung disease and bronchopulmonary dysplasia, there's a transition to a chronic phase of ventilation. I'd like some comments about, does that actually exist? And then if that is true, how do y'all transition that child to a chronic phase of ventilation? And what does that transition look like? And when does that happen?
This is probably the most common question we have in this tiny field of BPD. You are correct. When they're first born, we very much want to be as lung protective as possible because you have a window where you can prevent the development of BPD, or we like to think we can. For those babies that were unable to get off the ventilator, we do start to see shifts in their physiology. For every baby, it's a little different. I've had, I think, the sickest twins I ever took care of. I could tell their physiology was changed at 2 weeks after they were born, which for them was 24 weeks corrected, right? So still tiny, tiny. And then, there are some babies where you're starting to see that resistance-dominated physiology come into play, in the mid-30s, corrected, even up into the 36-week mark. So I wish we knew when. It seems to be for every baby, it's a little bit different. And so, the way I'm counseling my trainees about this is the baby's going to tell you that your strategy's not working anymore. They're very clear. Their oxygen will go up. They'll become really touchy. That'll be the nurse that says, don't examine my baby. You'll just cause them to desat and spell. And certainly they'll become, hypercarbic, although that's a later finding. So the baby's telling you, hey, my physiology's changing. What you're doing is not working. And I do counsel our neo fellows as well. Like if you're thinking about using steroids, if you're thinking about albuterol, in theory, those are all interventions that would reduce resistance, right? So I advocate for slowly transitioning the ventilator before throwing all those medications at the baby. They usually respond quite well to that. So you're correct. There is a transition. We're not sure when it is, and that can make it very challenging to take care of these kiddos.
So it seems when the baby starts acting like a BPD baby, that's when they have BPD, which like intuitively makes a lot of sense. But
right.
I imagine you might also see a rising difference between the PIP, the peak inspiratory pressure and the plateau pressure, or you might start seeing lots of EQ mismatch if you have an end-tidal CO2 in line.
Yep.
Are there other like clinical factors that you look at other than just like those like somewhat intuitive like clinical features that you describe how these babies behave and act?
Yeah, it's simple, but I go back to physical exam. It's not fancy by any means, but they're working to breathe. They're uncomfortable, they're dysynchronous, and they don't have chest rise with the ventilator breaths. And when they start acting like that, it tells me we need to make a change. And that's in coordination with their oxygen needs will slowly keep going up and up and up and up, despite what you do.
So you mentioned the common illness script of a baby comes to you from what other pathway, and you note them to be chronically undersupported. Can you tell us what that looks like and how you start to evolve their vent settings towards something that might be more adequate?
Yeah, the classic picture we see most commonly is a baby that when they're awake, they're working really hard to breathe. They're usually requiring a lot of oxygen. Sometimes they're requiring a lot of sedation, sometimes even paralysis, usually on steroids, usually on all these props. That's usually how they present if they're kind of undersupported. The babies that have a lot of BPD spells that you hear about and that are quite scary. Our approach here is we would just transition their settings in one swoop. And it's kind of magical, to be honest, because you can see when you drop the rate and you increase the tidal volume to get chest rise with those slow ventilator breaths and give them the long eye time, give them the exhalatory time, they just immediately relax. You can see it within 5 to 10 minutes. The breathing slows, the baby's less agitated if they're awake. It's really kind of remarkable to see. When I do consults with centers who are making this transition, I think it's intuitive for us all to want to do it in a stepwise, small approach. That makes sense, right? Make a small change and see how that impacts the baby. And that's how I certainly was trained as well. But with these BPD kiddos, even if they're kind of in the middle of the road in settings, they're not doing well. You really do have to kind of commit to trying this strategy full on to see if it's going to help the baby.
I'll ask you a challenging question here. I mean, making big changes on the ventilator is almost the antithesis of how these babies are managed. You know, how often do we hear from the parents, like, my baby likes making small changes and one change per day at the most? If I were to give you a patient who's undersupported with severe BPD, perhaps they're only getting 6 per kilo tidal volume, a rate of 30, and they're hypoxic and they're hypercapnic, maybe peak pressures in the upper 20s. Like, how drastic of a change would you make? And please give me some example of numbers.
Sure. So if I inherit that baby and, they're older, right? I'm assuming they're
Yeah. Our case today.
Yeah. Then for sure, I would take that rate of 30 down to probably, being honest, like 14. I'd take that eye time probably to 0.8. And then I'd stand at the bedside and I'd turn up the PIP or the tidal volume until I get chest rise. And that usually is PIPs in the 40s or higher. And that's usually tidal volumes like around 15 per kilo or higher, depending on how sick the baby is. The other key feature I'll mention, because I think it's really important for these kids, is if they're getting a pressure support, I would drop that way down to probably 8 to 12. Then I probably wouldn't go higher than 12. And the reason for that is because I want the baby to feel like when they want a breath, they can get a little breath, right? But I don't want them pulling these huge volumes, especially if they're tachypnic, when they're not going to be able to exhale that. So all that air is going to be going in and in and in, and they're not going to have time to exhale it. And essentially, then you're on like an assist control mode, and you're going to be back in the same problem you were in before. So I want them to comfortably get a little breath when they want one, but I don't want them to participate yet too big with those big breaths. Does that make sense?
It does make sense.
Yeah.
And I think the stark difference between the support breaths and the mechanical control breaths, it really sticks out to me because we take care of patients with acute lung injury, ARDS, and it's a common mantra, like, we don't want kids overworking on the ventilator. We don't want them tachypnic and undersupported. So when we start giving children full support on the vent, it would be pretty common to give them increased pressure support to try to at least give them a comparable volume that stands out as very different. And if I understand correctly, this is all about trying to avoid air trapping. And you're not going to be able to make this child not tachypnic unless you sedate them heavily. So it's the way of finding the balance there. Is that correct?
Exactly. And I will say too, though, if you're giving them enough PIP tidal volume with their vent breaths, they will get more comfortable and they will get less tachypnic over time. It's not perfect. There's going to be moments, everybody has bad moments. But in general, overall, they will become more comfortable where you'll need less sedation.
Yeah.
But you're right. The pressure support component is very counterintuitive. And so it's very common for people to kind of try and match that with what you're doing with the vent breaths. But you're right. It'll lead to overdistension, air trapping, obstruction, and spiraling. So yeah, we keep that very low purposefully. And there's like a transition period, right? Of course. But I promise, as long as they're getting the tidal volume, the PIP, which is higher than we want to do almost all the time, they will start to get more comfortable. In my unit right now, all these kids, they're comfortable. They'll have moments where they're stooling and they'll breathe a little quicker, but they settle out. And so that dysynchrony you see with the ventilator does get better when at baseline overall they're more supported.
So you mentioned that you were going to go for maybe like a rate of 14, pressure support of 8 to 12, and then a real high tidal volume or crank the pips up to the 40s. What are you doing with the PEEP?
Yeah, PEEP. It's so controversial, even in our world, even among centers in the BPD collaborative. I can speak to my experience with PEEP because you need a PEEP high enough, of course, to maintain your FRC, to avoid atelectasis. For us, we've found that is about 8. And then our clinical experience here has been if you go much higher than that, you start having lymphatic obstruction, over distension gets worse, then you might have some head and neck edema coming into play. So we really don't change PEEP. It's not something that we titrate here. So we usually set our PEEP either 8 or 9 for our patients and leave it. And then the other settings we're titrating if we need more support would be that tidal volume. There are some centers out there that will do like PEEP titration studies, that will do titrating of the PEEP during spells. There are some centers that do that. We have not found that to be at all helpful for our patient population. And so part of this whole management approach is having a shared mental model with providers. And so we just kind of took that out of the equation. So we give them a good enough PEEP and then we titrate our other settings, and they do quite well that way.
And is this sort of assuming in your population that there's not much tracheomalacia, bronchomalacia?
I think there is. I think all patients with BPD have some degree of it. I think we don't have a perfect way to measure it. Unfortunately, I think the studies that we have are one moment in time, not reflective of the 24-hour period at the bedside, which is so fluid. So I think we have an imperfect way of measuring it, number one. Because we have here in the past tried like PEEP titration and it didn't make any difference. We tended to accept that probably our babies have some degree of malacia, but we don't widely vary our management approach for that. The only cases where we would kind of go off book would be if we had a patient with such bad malacia that we know we're heading towards a trach anyway, we would probably do less extubation attempts, but our ventilator approach stays the same for those kiddos.
And I do wonder, and might be my own NICU ignorance, if the BPD spells can be conflated with the presence of malacia, if one is blamed and the other gets better.
Right. I just kind of assume all these kids have some degree of malacia, honestly. There's not much I can do about it. And the ventilator approach we're using seems to do great with them without us moving the PEEP around too much.
So hearing more about how you described setting the ventilator for these children, you might need peak inspiratory pressures in the mid 40s, PEEP, single digits, 8 or 9, giving you a driving pressure at least in the mid 30s. And in the PICU space, there's talk about in ARDS, like a driving pressure greater than 15 could be injurious. So this, of course, piques our interest. Is there a point that you feel like elevating the driving pressure, elevating the peak inspiratory pressure past a certain threshold is not helpful and injurious, or is this very much a unique case-by-case scenario?
Such a great question and such a valid concern, right? We're trained to not cause more injury. I will say this physiology gets better over months and months and months, but in the moment it's pretty static. So you're not having rapid changes in your physiology in these kiddos. I will say using PIPs, and to be honest, we have such sick kids here, most of our PIPs in their low 50s. We don't see air leaks. I've had one air leak and it was related to a pneumatocele. So we don't see air leaks with using this approach. And I kind of wonder if you have an under-supported baby and you're really only ventilating and working with the very minor healthy parts of the lung, I wonder, is that causing more damage to the healthy parts of the lung? Because that healthy part of the lung is supposed to take over and do everything for the baby, as opposed to kind of diffusely making sure we're supporting all of the lung. That way that healthy part isn't getting berated. So that's kind of what I would think about. We don't really see consequences of using these high PIPs. And to be honest, clinically, you'll see them stabilize so quickly. It's pretty reassuring when you see the clinical picture in front of you, more stable and really starting to heal.
I can visualize kind of what you're saying, where you intuitively, a patient is well supported when they're not working to breathe, they're not tachypnic. And we described this paradigm shift of acute phase ventilation versus chronic phase ventilation. And of course, the work you're doing at your center is evidence to the success of this. I'm curious, there's a few studies in pediatric critical care that every fellow attending knows. And like one of these is the, ARMA trial with the low tidal volume ventilation in an ARDS. What evidence do we have that supports this chronic phase of ventilation and in line with what you're describing?
Yeah, it's very limited, to be honest. We don't have randomized controlled prospective studies. What we do have is a lot of data on the physiology to understand what's happening in terms of physiology in the lung. And then apart from that, we have outcomes data. So it's not great. It's not a perfect system. But I think most of neonatology is that, unfortunately. We don't have a lot of high quality evidence for neos, especially this population of 22, 23 weekers, which, we weren't even saving several years ago.
It seems that from a monitoring standpoint, clinical monitoring, i.e. looking at the child, listening to their chest, making sure there's full exhalation, they're fully supported on the ventilator, seems like it's key. Do you have any other types of invasive monitoring that you commonly use in these kids? Like one example might be, is frequent blood gases particularly helpful? Tell us more.
Not in my opinion, no. So we recently published a study about how we don't use routine blood gas monitoring in our kiddos and showing absolutely no difference in outcomes compared to the group that did get blood gas monitoring. So we don't feel like you need blood gases to impact the most important outcomes you're trying to get for these kids. Of course, like mortality, trach, pulmonary hypertension, growth, things like that.
So it's pretty common, at least I say it's common. I've seen it in the past where these children with severe BPD, if we have an end tidal in line, we'll see the end tidal go from 60 to 120 over the course of a few moments and then come back down. I can only imagine somewhat of a random number generator drawing a blood gas is. It seems like there's a prioritization of comfort and trying to avoid what we call BPD spells more so than making the CO2 a black number in the EHR. I guess the answer might be no, but is there a particular level of CO2 that you're uncomfortable with? Like their best CO2 is only in the 60s, and that's problematic from a pH standpoint. Is that hitting home at all?
Yeah, you bring up so many good points. Blood gas monitoring is not accurate. I don't consider it accurate because these kids are big. You stick them, they hate it. It's an abnormal number. It's going to be inaccurate. And then 2 minutes later, it's not going to be reflective of how they're doing. And we do know repetitive pain leads to worse neurodevelopmental outcomes. So there's a lot of negatives with routine blood gas monitoring. With that being said, it's a hard culture shift, right? A lot of people like to see that number. What we tend to follow is our weekly chemistries. We're taking a look at our bicarb. It's more of a long-term, in my mind, trend that I tend to follow. So I do find that to be helpful of getting a chemistry once a week or once every other week to follow that trend. And no, our practice here is we do not aim for certain CO2s. But I will say, when we've had to get a blood gas for we're back transferring a patient or whatever reason, it's always normal. And so we know that if our baby is comfortably working to breathe on clinical exam, the times we've always checked a blood gas has been normal. And if you have a baby that's working to breathe and is not comfortable in exam, you're not in a good spot, right? And so at that point, we would just adjust our ventilator and support the baby more and really get back to the basics of clinical monitoring. It's hard to do in this day and age when you have all these tests and all these wonderful adjuncts to how we manage our patients. We just kind of argue that sometimes the more we do, we're risking developmental outcomes later on. And sometimes you'll find things that you kind of already knew based on the clinical picture. And does it really help you change your management?
Oh, yeah.
I guess is what I would argue.
Love that you're playing the long game. It sounds like you're looking at the baby, inviting yourself to the bedside, which nobody could argue with. If I only gave you a weekly bicarb on the BMP trend, what number would you like and what number would you not like?
Yeah, it depends if they're on diuretics. So if they're on a diuretic like Lasix, then I tolerate higher because I know that's normal. And I also would want a trend. I probably wouldn't get too excited over one. But we do see fluctuations. So if I have a baby that I just extubated, I will see it rise into the 30s, sometimes even a low 40 as they're sorting themselves out and getting used to the new lower level of support. So I don't necessarily have a cutoff where I would panic. I would kind of bring that number back into the whole clinical picture. So if I have bicarb that's 40, but my baby looks good, I'm probably going to let it ride. If it's high like that, the baby's working to breathe, then I'd probably, reintubate the baby or do whatever I needed to do to escalate support.
I think another dichotomy is in the PICU, vent settings takes up the first 30 or 40% of rounds, talking about how can we liberate this patient from mechanical ventilation. And if I'm gathering correctly, it seems like the vent settings are set, you make sure the baby's well supported, and then you might not even discuss vent settings a whole lot on rounds that day. I like your comment about that. And then it also seems like you're prioritizing like occupational and physical therapy and, nutrition so much more than like, how can we turn the vent settings down today on rounds? Correct.
One of my colleagues, Dr. Keel, jokes all the time about how in a BPD unit, we never talk about the ventilator. And he's right. So you describe it perfectly. Our goal is to get our babies comfortable. And once they do, we're hands off the vent. And then the only thing we're changing, if they're comfortable, is we're weaning our oxygen. So that's our parameter that we use in our unit as kind of a benchmark to assess for extubation readiness, or if the baby has a tracheostomy, we're using that to help us understand when would be a good time to start weaning the vent. And so, correct, if you have an unstable baby and you're in that unstable acute phase of BPD, we're not weaning the vent, we're supporting the baby, period. And then we're focusing on growth because we know that linear growth equals lung growth. I've had a few recent studies where we know if you're achieving good linear growth, you come off positive pressure faster. And we know if you're achieving good linear growth, you have better PFTs at discharge and post-discharge into childhood. So we know linear growth is key, and you're not going to be growing if you're constantly working to breathe. So it's a very big mindset shift, which is so hard in the ICU setting to go from, I need to wean to, nope, I'm going to park you here and grow. It's hard to do. It's really hard. But that's what's best for these kids, we think.
Nice. Now, you do make me realize that we didn't get your details about FiO2 and what you like and what you don't like. So let's say, okay, so we've given you this patient, they're in the PICU stage on a tracheostomy, sort of getting ready to be stable for a subacute facility or home. You've changed their vent, so now they've got their rate of 14, pressure support of 8 to 12, high tidal volume, PIPs in the high 40s, PEEP of 8. What FiO2 are you looking for in this chronic phase? What would be too much for like a chronic support?
For like assessing homegoing? Is that what you mean?
Or even just I'm parking them in the PICU, I'm optimizing their ventilator.
Yeah. So it depends to some extent on the severity. Like I'll have some kids that are still on the younger side, like maybe 40, like a month they'll corrected, 44 weeks corrected. That are still requiring 80 to 90%, but they're stable, like they're comfortable. They're just taking a really long time to wean. That's fine. For us, if we're going to try an extubation, we like them to be less than 40%. In our mind, there's been enough healing, we're well supported enough where we feel like, and our data shows our babies do really well when we use that number for extubation. When I'm thinking about like homegoing or chronic care facilities, same thing, like 35 to 40% usually indicates stability. These kids take a long time to wean their oxygen if you're doing it appropriately, I think. And we see this too sometimes with like floats that might come in and crank down the oxygen by 10% in a night. And then for the next 3 days, our kids are falling apart. And we're like, what's happening? They just need really, really slow weaning. And so when I'm counseling parents, I say like a 1% a wean is amazing. And if we get faster than that, great. But there's a really low expectation for doing it quickly. Because you'll see the FiO2 come down as you're getting the lung healing happening. So it's a slow process. And because it seems to be most reflective in our mind of VQ matching, we do use FiO2 as like our guidepost for extubation, for low flow cannula, and certainly for when we're considering weaning our home ventilator tracheostomy patients.
Wonderful. I feel like it's a common problem in this patient population of having patient ventilator asynchrony. And do you mind just describing, do you see that as a common problem? If so, is there a particular etiology of asynchrony and then ways to mitigate that?
Sometimes we'll see it. I think air leaks are a problem. We see air leaks play a role in how the ventilator interacts with our patients here, sometimes to the point of autocycling, which is very scary. And there's not much we can do, honestly. And I hear this from a lot of centers that asynchrony tends to be a problem. It's a problem for me if the baby's uncomfortable. If the baby's comfortable, I tend to ignore it. If the baby's uncomfortable, then I would try optimizing the support along the same pathway of the settings we've already talked about, maybe upsizing the leak, things like that. But to be honest, most of the time, if the baby's comfortable and well supported, you can ignore it and they're going to do fine.
Yeah. Is there a role that you see for NAVA or some kind of advanced mode like that, or do you find it's usually not necessary?
There are some centers in the collaborative doing some early studies on NAVA. We haven't implemented that here because it kind of goes back to my thoughts on the pressure support. So NAVA tends to be patient-driven, right? And so anytime that baby's tachypnic or working on a poop, or anything that's stressful, and they get tachypnic, they're going to, in my mind, lead to that overdistension breast stacking picture I'm trying to avoid. So it's not something we've implemented here. So I can't speak too much on its success. There are other centers that are working on it. I've heard kind of through the grapevine that if you can get a baby comfortable on NAVA, which is rare for BPD, they're kind of stuck there. And it's hard to wean them from that. More to come. We have a couple studies in the collaborative on that right now.
We use the analogy for other things, like I think we used it for CDH, or our guest did, where it's like making good pizza, right? And you're like, that is not in our recipe. Okay, we're doing the big breaths. It helps them feel better. And then the synchrony matters less, maybe.
Yeah, exactly.
I feel like you've shared with us your mental model for determining when a patient is ready to wean ventilation, that being they're comfortable, they're not having these BPD spells, their FiO2 requirement is low, being at least around 40% and maybe improving trajectory. Will you tell us more about like the general pace and strategy for weaning invasive mechanical ventilation in these patients?
Yeah, to some degree it matters to what your outpatient team is comfortable managing. Most centers, the outpatient pulmonologists who are going to be managing home vents like lower PIPs than we need in the NICU to manage these kiddos. So for us, that most routinely looks like PIP weaning. And we do it very slow. Back to your point of these parents wanting slow changes, this is when that comes into play, where we would wean the PIP by maybe once a week. It's painfully slow sometimes. And if your baby's like super not even noticing that, maybe by twice a week, we wouldn't go more than that. Because it can take some time for them to show they're not tolerating it. And it can be subtle signs too, like more sleepy, increased emesis, things like that can come into play as we're weaning. Usually I start hearing a lot more about teething pain when we start weaning the vent. There's just a less tolerance and there's less support to make it through the daily challenges. So we tolerate that to a certain extent, with our goal. We can't stay on a PIP of 52 forever, right? We're just mindful that we're doing it slow enough where we're not causing big back steps.
And out of curiosity, do you manage these patients on pressure control ventilation, or what mode do you use?
We use pressure control ventilation because all our kids have air leaks. And it's hard to ensure you're getting that volume. With the way we manage our patients, we have really low rates of airway anomalies, and we think that's related to having air leaks. And we feel comfortable, of course, with the PIP compensation there. So we use pressure control. But in theory, you can do this with either volume or pressure control.
Now, you brought something up that's, first of all, you're giving me so much to work with my next BPD patient, and I'm excited. Okay, you bring up what PIP do you need to get them to their next step, whether that's home or a subacute care facility. We were talking about here in New York, it does seem like we have significant amount of subacute care facilities, and sort of, we love to get them back to their borough, near their parents and out of the ICU. I feel like this is me calling the BPD hotline and ask, of course they're not going to take someone with a PIP of 50. How do you deal with that?
It's tough. And we're very lucky at our specific center because we don't have a big push from insurance companies to get these kids out. It's incredibly hard on the families, I agree with you, to be far from home. Essentially, our hands are kind of tied. And these kids, they just take time. And we go as quick as we feel like we can, but even that takes a long time. It's hard. Sometimes you'll find facilities, like we've had a couple of back transfers to facilities that are comfortable with higher PIPs if you can really make a case that, no, this patient's incredibly stable. Like this will be the most stable patient in your unit. They just need a long time to wean the support.
Something that piqued my interest earlier in our conversation is you mentioned that your center has a low tracheostomy rate. And when I reflect on my experience up to this point, nearly all of these children have had a tracheostomy. And you also alluded to earlier about, thresholds for extubation, and that might just be your FiO2 around 40%. I'm curious, like, what level of ventilatory support do you actually liberate these children from invasive mechanical ventilation? Are we extubating from a PIP of 30? Like, what do you typically do here?
Yeah, great question. So looking at our data, we found that it doesn't matter what the PIP is. So we don't wean our PIP prior to extubation. So 2 days ago, I extubated a kid from a PIP of 49.
No. No, you did not. What?
So the criteria we found that matter are FiO2, again, reflecting your VQ matching and overall stability. We say less than 40, I tend to have more success around like 35%. And PEEP, we know that if you have a PEEP higher than 8, it doesn't really tend to go well based on our data. Apart from that, I want my baby to be growing, so they're not catabolic when I put them in a new challenge. But those are our criteria. And so we routinely extubate from PIPs in the high 40s, even low 50s, and our babies do very well. But I do think that's partially because we're not always weaning their PIP. You know, back to that point of like, once we get them comfortable, we leave them. So that baby, when we're ready for extubation, is going to be in a whole different spot. Like, they probably didn't need that PIP at 52, right? We're just not pushing them to come off it because I want them to grow. So yeah, honestly, we do it all the time. We have a really great success rate. Our trach rate here is 4%, and that includes kids that come with an existing trach. So we're able to get these kids extubated pretty well from these very high settings, which again is probably surprising and counterintuitive.
What are you extubating them to?
So we use CPAP or NIV.
You'll do like a 30/10 rate of 30 situation, NIV occlusive prongs?
I would probably do a lower rate. We'd probably do like a 20 rate. And then, you know, we kind of have a threshold for our PIP. If we're on NIV and our PIP is getting like 26 or higher, in my mind, that kid just needs reintubated and time for more growth. Otherwise, they tend to kind of linger chronically undersupported on NIV for a long time. And we kind of have this saying, you got to go slow to go fast. So if you're really kind of struggling on NIV, to me, you just need some more time on the ventilator growing.
That's so fascinating, though, like liberating these children from invasive mechanical ventilation with PIPs in the 50s, you know, cutting their mean airway pressure by more than half when you liberate them. And I think reflecting on to go fast, you have to go slow. And boy, is that a paradigm shift for most of our patients in the pediatric ICU.
It's so hard in the ICU, yeah.
This is some NICU magic right here.
It seems like the best way we can promote health for these children, that being limiting the addition of comorbidities and promoting the best possible neurodevelopment, is giving them the best ventilatory support that they need and then optimizing their nutrition. Any other comments on how we can just promote, you know, well-being for these children to, you know, limit the addition of comorbidities that happen during their ICU stay?
Yeah, you describe it perfectly. I think for a well-supported baby from a respiratory standpoint, if you have pH, it's going to be healing. If you don't, you're preventing it by providing optimal respiratory support. So then you're going to prevent cor pulmonale, which is a cause of mortality. Focusing on the growth is what really gets you out of this in the long term. So you're right there. And then we're also trying our best to promote neurodevelopment. I think you asked me this earlier and I got off track, my fault, but we do prioritize developmental therapies as much as we can and positive experiences. So feeding on CPAP is something we will do for the stable baby. Therapies, all of our kids get out of bed a lot, even with ET tubes. So we're promoting positive experiences over that noxious stimuli of repeated labs and heel sticks and x-rays and procedures, because we know these kids are with us for a long time. And we know we're taking care of them during the period of the most rapid brain development they have in their lifetime. Everything we do, we do carefully, and we do ask ourselves about our interventions daily. Are they to promote development? Are they maybe something that could inhibit development? And that goes back to sedation as well. Like, if you have a comfortable, well-supported baby from a respiratory standpoint, you don't need sedation, and that will impact their development too.
Wow. Well, this is really powerful. It really highlights the positive culture of your unit, and I'm sure the positive impact of the patients and families that get to stay with you.
Thank you. I appreciate that.
It's a real challenge, I think, for healthcare systems to know how to physically place these patients to best take care of them, because NICUs are busy places. Like, the baby's born every day that need to be admitted. PICUs are also busy places, and there's quite a bit of heterogeneity of pathology in the pediatric ICU. And with BPD patients, their pathophysiology is very unique in the strategy that to take care of them. We've explored quite a bit today. It seems what you have there at Nationwide is unique and wonderful for these babies, but healthcare systems aren't going to be able to like spontaneously grow a new unit. How do you feel like most of these tertiary care hospitals could best take care of these patients? What does collaboration look like between NICU and PICU that's done well?
Yeah, you're correct. We are very fortunate that we have a dedicated BPD unit. That's not the case everywhere else. And so you have these kids mixed in with your acute population, and that's really hard. I think one thing that is probably going to be the most helpful is to somehow create a shared mental model. And, that can be with a smaller group of people that are invested in these kids and want to take care of these kids and are passionate about these kids. And getting everybody on the same page is probably one of the most important things for changing their trajectory, more so than what PPUs. It's getting all the providers caring for these patients to buy in to the same approach so that every week or every 2 weeks, as people are rotating on and off service, and as you have different bedside nurses and RTs caring for these patients, there is a shared mental model on the long-term plan, the plan over the next week, the next month, to help these babies have more consistent care. So I think in the absence of being able to cohort them independently, which of course, not many people are going to be able to do that, it's more getting a shared mental model among their core providers.
And I do see that there's so much value in perhaps a baby like this having a core group of nurses or a core group respiratory therapists who take care of that baby on a rotating basis, and also just maybe like physician champion with a group surrounding him or her. It sure seems like there being multidisciplinary representation from NICU and PICU could best take care of these kids.
Absolutely. So I trained at an institution where we implemented a BPD program in training, and I think a key in that and having that shared mental model in a smaller group of champions is right now probably in most units, those severe BPD kiddos are the most unstable, right? They're scary. Nobody wants to take care of them. But when they're given the optimal respiratory support, I'm not joking when I say they become the easiest because they're stable, they're not spelling, you're not making a change but once a week, and people want to take care of them then. So I think it does kind of go hand in hand. You get them well supported, and then you have a group of champions that are comfortable with this chronic care model, and you probably have success that way.
Yeah. Even changing the culture and the interest of the team. That's wonderful.
So we've talked a lot about the medical care of these children. We talked a lot about the perspective from the patient, perspective from the physicians taking care of them. These poor families are along for an incredible roller coaster of a ride with many ups and downs. And I'd like to know just more about how you counsel them to recognize, we're in this for a long haul, and there's going to be bad days. There's going to be good days. There'll be days and weeks that go by that you see not many changes happening. How do you give them that perspective of what to expect?
Yeah, I think that's one of the most important things we do is when our parents come to our unit and before they come, we are sitting down with them and we have what we call a welcome to our unit care conference, where we're very transparent that our approach is chronic care. So we expect BPD to get better. We expect that to be over a long period of time. So I'll counsel them that we're no longer thinking about shifts. We're not even thinking about days anymore. We're thinking more weeks and months. And you can see their face change. It's hard. It's hard information to hear and to kind of shift. These are the things we're looking at for stability. This is why we're no longer getting blood gases every 4 hours. And this is why. And I think explaining the why behind it, I've never had a family that didn't buy into this way, is just explaining we're doing this for best outcomes. We're doing this for your baby's development. We're doing this for their growth. Explaining the bigger endpoints that you're targeting really helps them to get bought in. And I think just owning that upfront, that now the pathway forward is different and slower, really shifts their expectations and helps a lot with the adjustment.
Well, as we wrap up today's conversation, Dr. Audrey Miller, is there any resource, anything you want to highlight or share for the PedsCrit listeners?
And we encourage you to talk about your consultation service, for sure.
Oh, yeah. Give us that number. Yeah.
Sure. The BPD Collaborative has a lot of articles, I will say, which are wonderful. And then my group here at Nationwide, we do offer a free consulting service just through our physician direct line. And it's 24 hours a day. There's always a BPD doctor on call. And talking through consults is one of our favorite things. We love it. So if there's ever a patient you want to run by us, we're very happy to talk you through it. And we'll even do like longitudinal consulting where we'll talk to teams as they're making ventilator changes. We're happy to do that. We love to do that. And there's a lot more articles out there now, I will say, related to the physiology and the why behind this approach that are always great to check out. Can send some your way.
Yeah. Well, we'll be sure to link to several of these in our show notes, but gosh, it's been a real pleasure. I've learned so much. I'm so excited to share this with the listeners, and thank you for this unique consult.
Well, thank you for the opportunity. I'm so happy to be here and chat with you today.